Welcome to Human School. I'm your host, Dr. Patil Armenian. After 4 years of college, 4 years of medical school, 4 years of residency, and 2 years of fellowship, I thought I was done. I did my time, got my degrees, and now I was just gonna live life. Well, think again. Some of my greatest schooling has come after my formal education was complete, and it keeps on coming. Join me at Human School, where we can learn together. I'm an emergency physician and medical toxicologist working at a large teaching hospital in California. I'm also a mom, wife, sister, daughter, and friend. Whether you work in healthcare or not, you too lead a busy life. Together, let's work on how we can thrive in all of our real-world roles. On this podcast, we'll dig deep into what it means to constantly learn and evolve, to be human. Every other week, I'll share some of my personal stories, interview inspiring people, and offer tools to help you learn more about yourself. Being on the front lines in the ER, you learn a lot about life and death. And though my philosophies were born in a busy emergency room, they can apply to anyone trying to live a joyful life here on Earth. Please listen, share, and subscribe to this podcast, available on Apple Podcasts, Spotify, or wherever you get your podcasts. Follow me on Instagram at Human School Podcast, and feel free to let me know what topics or guests you want to hear about. And if you like the podcast, don't forget to rate and review it. Hi, everyone, and welcome back to Human School. Today on with me, I have a very special guest, one of my best friends and also my boss, Dr. Danielle Campagne. Hi, Danielle.
Hi, I'm so excited to be here today with you.
Thanks for coming on. Now, let me introduce everybody to who Danielle is, and I'm just going to talk to you with first names because we're on first name basis. But, we've been friends for almost 20 years. Danielle is also the chair of emergency medicine at UCSF Fresno and at Community Regional Medical Center in Fresno, California. We're the busiest ER in California at this point, busiest trauma center, most critically ill patients.
It's hard to tell, it's always in the numbers, but we did see 123,000 patients last year. So I guess we got to compare that to other institutions, but we're a pretty busy place, that's for sure.
It's a lot. It's a lot. And she's the boss. Also, she's the medical director at American Ambulance, which is our largest ambulance provider in Central California.
Yeah, it's a very cool place. Lots of people doing amazing work. And so it's really fun to work with all these great organizations.
Did I miss anything? You have other jobs too, I'm sure.
Oh, I guess I get to be a mom. That's part of my job, a wife. And I also am a doctor, and so I can take care of patients too. And a teacher, because we have a residency program to teach residents. So it's fun.
I can't believe I didn't lead with mom and wife. What is wrong with me? But it's because we're sitting in your office right now.
That's right.
Right. We're biased because we're at work. Now, Danielle's done a lot of really cool things over the years, but I have to say one of the qualities that I always see in you is that you think of the whole group, whole community. It's never just about you or your advancement, but you just get an idea and then you think everybody should do this and I'm going to make it happen for everyone. Does that sound right?
Yeah, it's funny when you put it in those words because I don't think about it that way. I always think about it as like, I happen to be in whatever situation or whatever experience. If somebody else had experiences, how can they do it better or more efficiently than I did? Like, how can I make the world a better place, basically? And so for some reason, it probably drives my family and my friends nuts because I'm always like, all right, let's do this. How do we make this affect more people?
You do a lot. You don't have a lot of downtime, but it's inspiring. I mean, even just going back, we were residents together. So for those of you who don't know, that means we did all of our ER training together. I remember a couple things, even just back when we were residents, right? We're babies, like we don't know anything. But you, I think, had gone through a pediatrics rotation and you realized, oh, there's all these things we need to know off the top of our heads. And you made these cards that then you gave to every resident. We had them in our pockets. And you basically told me, you were like, you just have to memorize this. And I did.
It's so funny, but it's true. So there are certain dosages and medications and joules for electricity that you have to memorize. In kids, it's all weight based. So it's stressful, right? In the heat of the situation, you have to know it. And you got to think about when we were going through residency, there wasn't like Apple iPhone in your pocket. It was, we had, I think, what were those, Palm Pilots or something like that when they were called. So the fancy people had a Palm Pilot, but everybody else had like pieces of paper. And so I was like, you know what? I'm going to make this card. And on one side, it listed the meds. On the other side, it listed like equipment. And I remember I made it green, like it's like fluorescent green, and laminated it. And I gave it to everybody. I was like, keep that. It's so funny you mentioned this. One of our other colleagues, Dr. Sue Spiano, just said, I still carry it in my pocket. She was also in residency with us. So she carries that same card, is wrinkled up from many, many years ago. It's funny now, I've been thinking about that. So I went through a pediatric code, and I just realized I had those numbers, but they were hard to grab fast. They were hard to, it's like, how can we make this easier and a better experience for all my colleagues? And so that's where my mind went. So I was like, great, I can make this, I can share this. Maybe it'll help someone else not be so stressed out and want to pee their pants when they have a really sick kid that they're trying to do their best on and not have to search for a number. So I'm glad to hear it's still out there. And I'm sure now there's a lot of other resources people can use for the same card, but it's just a nice way to collect that data.
Well, I'm still sad I lost my card, so I think we need some fresh cards. And I will say, like, when you're in the middle of a code, that means somebody is dying and we're trying to save their life. You don't have time to look at a phone or to look at anything else. You really have to have certain things just memorized cold, like your dose for epinephrine, or, how you're gonna put a breathing tube in a small child. Like, you have to know these things. And so any tools that can help you matters. And I hate to say it to everybody, but certain things you just gotta have memorized.
Right. I think that card helps you memorize it, because I used to carry it around and remember, and like you look at it while you're standing line at the bank, or you look at it while you're waiting for the restaurant to sit down at the table. Like, it's like a flashcard essentially. And I think depending on how your memory works, having a flashcard around all the time, so you do have, now of course, Patil, you and I are many years out from training. These numbers are solidified in our brains and will never leave. But when you're a young trainee, you have to find some way to get it into your brain.
Yeah. I remember always staring at the card, and then also, like, you need muscle memory for things. I don't know why this just popped into my head, but I always carried a 10 cc syringe in my pocket, and I was always like using the syringe, because when you're putting in a central line, you have to have hand strength. And I didn't, because I'm a weakling.
And so that was a hand squeeze ball now, a stress ball.
Yeah, I should have used a stress ball. But yeah, that was like one of the little things. Another thing I remember was that you introduced video laryngoscopy to our department when we were residents. And for those of you who don't know, when we're intubating someone, so when we're putting a breathing tube down someone's trachea so that we can, in essence, save their life by giving them life-saving respirations and oxygen, one of the standards of care nowadays is that you do it with this video camera at the end of your blade, which is the tool you use. And back then that was unheard of, and you were like, no, we're gonna bring it in, and we're also gonna study it and see how much faster we can be with it.
That's right. And it was great. It was a great opportunity for me, because there's a new technology, it's being used other places. Let's bring it to our home and let's teach everyone how to use it. Of course, we studied it. We published a paper on it about how, the effectiveness is about the same, but the ease of use and everyone in the room can see what you're doing, which is really important if it's like a burn patient or somebody you really want to look at that cord, you want to look at that airway. So now everyone in the room, the surgeons, can see what it looks like. So yeah, but it was a neat process as a resident to, teach your fellow residents, teach the faculty, show everybody how to use this, and really create like a team and to roll that out. So once again, we're trying to make it better for everyone.
Well, and now, right, this many years later, it is the standard of care. And we start with video laryngoscopy first, typically, and people can't really imagine what it was like without it. But when you brought it to us and when you were rolling it out, I remember everybody being like, what is that? Like, if you're, if that's what you need, you're not good enough to intubate. And it's like, that's just not the case.
Right. Now it is the standard. And if many of you had surgeries, I'm sure anesthesiologists are using it too. And it's like not a big thing, but technology, when it first is introduced, I'm sure the first person who brought a car to the guy who rode his horse everywhere, the guy was like, I don't need that car. I can be on a horse. And now you can imagine riding a horse to do your errands. So I think it's the same way as new technology comes. People have been using the old technology. You're like, why do I need that?
Now, okay, let's talk about our COVID project. So, remember when COVID first was being talked about? I remember it was February 2020. We were kind of hearing rumblings, and then March was lockdown, and you were in charge of basically education for all the medics at American Ambulance, which is a huge organization, by the way.
Yeah, and they have about 300 paramedics and about 500 EMTs. And prior to this date, all training was in person, right? So in person, in classrooms. They have multiple lectures happening. And yeah, Patel, you're totally right. When COVID hit and we went on total lockdown, there was no more in-person training happening. We couldn't get 50 bodies in a room with a teacher anymore. And so we had to really rethink how we're going to do education at a grand scale. And education is very important to me. Is how are we going to keep these paramedics and these EMTs, their skills up to date? And at the same time, actually, Steve Melander's his name was the operating officer at the time at American Ambulance, and he's wonderful. And he brought up, how about we do a podcast? He listened to podcasts a lot. He said, what about we do a podcast? And then I thought, okay, I'm not techie. I don't know how to do this. Okay, I can do a podcast that just our paramedics would listen to, about teaching, going through the protocols and, talking about cases. Then I remember recruiting my friend who is techie, Patil, and saying, hey, what do you think? Will you come on this podcast with me? I can't be the only one talking in this thing. And then, do you remember your response?
No.
Yeah, you were like, I'll only do it if it's for everybody and free.
Oh, yeah.
I was like, of course it'd be for everybody and free, but I don't know how to do that. And you're like, oh, it's easy. We'll get on Apple Podcast or Apple.
Yeah, Apple Podcasts, Spotify, all of it.
All the things. And I'm like, awesome. And then we recruited, at that time, we had a resident with us on EMS. His name is Sajid Bhakta, and he was very interested. And we're like, great. Now we got 3 people. Now we got a host. We're doing this.
And we had a producer, John Mark.
We had a producer, John Mark, who still works at American Ambulance, is wonderful. And from basically this little brainchild, we were like, oh, we can do this, and then we can provide education to our team. So that way, we didn't know how long COVID was going to last. It was a very scary time. So we were like, we got to be able to do this. And in my mind, I'm an optimist, an internal optimist. I was like, oh, it's going to be a couple weeks, just in case. Let's just make sure we can get education. And, then we can attach a test to it. We can attach feedback to it. But we got to get some means of getting education to a lot of people. That launched our podcast, which those of you listening can check out if you're a medical nerd like me and want to check out a medical podcast.
Yeah, it's called American Ambulance EMS Podcast, and we love it. We love doing it. Now we have a paramedic co-host as well. We tell paramedic stories and talk about cases, but that was, more importantly, that was our only social event happening during all of COVID, because I feel like a lot of people, they went back to normal, but those of us working in the ER kind of didn't. For a solid year, I feel like the once a month when we met in that room to record, that was the only time that I just hung out with a friend.
Right, because you think about it, our kids were on doing Zoom school, right? They were at home. Most of our spouses were doing work from home, everything went home and we would go to work, but we did record in our masks because, the whole COVID thing going on. So it was kind of half social for us and half get information out to our troops. And it's funny, the podcast is still going now, 5 years strong. And it's great. It's listened to. We use it for recurrent CE, but we have gone back to in-person CE for more skills and those kind of things, which is wonderful. So it is interesting, but I don't know, you probably know the stats more than me, but our podcast is listened to a lot of places more than just locally now.
Yeah, it's all over the world. We have a real group in Australia that seems to be listening. So shout out to Aussie medics. But yeah, it's really cool because it was just this small idea we had, and now it's just grown and grown, and we don't seem to be stopping anytime soon.
Right, because always things are changing in medicine and changing in EMS, and so there's always new topics to talk about, new concerns and new things, and so it's really a fun way to distribute information to the masses for free.
Well, and one of the most important things I think in just like in medicine is general, is pre-hospital medicine. It's like when something's happening in a business, in a home, anywhere outside, a crash, who do you think is going there and helping people? It's the paramedics.
Right. It's our EMS system. And they're the first touch. Right. So if you're wherever you're sitting and something's happening to you, right, we're all gonna call 911. And who's gonna come? Your first responders, police, fire, and EMS. And if it's medical, those EMS professionals you really need. They're there. They really start your treatment and start, I call like the train to lead you when you get to the hospital, right? Then they share with those docs, like, this is what I've done. These are the medicines I've given. These are the things that have worked. And then the doctors at the ER can continue with that or change that or go from there.
Yeah, it's so important. And then, we are in Fresno, California. So although our city and our hospital is pretty big, our surrounding areas are really rural, like extremely rural, some of the most impoverished parts of the state. That actually involves a lot of really long transports for a lot of our medics. And so that means that, let's say they're going from one tiny rural hospital to, let's say, a bigger hospital like us, or sometimes we even have to send out to even bigger hospitals. Then, those medics, they're taking care of really complicated sick people for a long time, right?
Yeah, and then we even have critical care paramedics you're talking about the transfers you're saying that would go from, a small rural hospital to maybe UCSF main campus or Stanford or down to UCLA, like big institutions, or to us here at Community Regional Medical Center for a specialty service that other hospitals don't have, or maybe a field paramedic. You fall off a mountain in Sequoia King National Park. There's going to be a park ranger that takes care of you, and then they're going to rendezvous with an EMS crew. They might be in the back of the ambulance with you for an hour and a half, 2 hours to get to us. Like, that's a long transport. If you fall off something in an urban city, the average transport time should be, 5 to 10 minutes to a hospital. But you're right, have a lot of rural areas that are coming for many miles. And so these medics are doing a lot of really neat things to help people before they can get to the hospital.
So you kind of like noticed that there was this need, right, for more critical care paramedic education. And tell us, what did you do about that?
Yeah, so just to fill everybody in listening, the difference between a critical care paramedic and a regular paramedic is a bunch of training. And so the critical care paramedic can, use a ventilator if you're on that intubation tube we talked about earlier, if you're on drips, like fancy medicines to affect your heart or to affect your blood pressure or to affect your blood thinning, depending on what your diagnosis is. And then if you're in a small hospital, maybe that doesn't have an ICU, or say you're having a stroke and you need a neurointerventionalist, or you're having a head bleed and you need to get to a neurosurgeon. These small hospitals, especially we have a lot of weather here in Fresno, like there's fog and you can't fly, they would then need to drive this patient to the big center that has those expertise. And so at American Ambulance, we have a critical care paramedic program. It's like an awesome core group of about 8 paramedics who've done the specialty training. And so it's a lot of hours of training on how to do this. And prior to right now, the only way to get that is you have to leave the state, you have to go to this course, and the course is a couple weeks long, and then you have to do hands-on clinical training. And it's very expensive, right? Of course, the agency to send these people. And think about leaving where you are right now, your homes, your kids, your families. So like, I got to go to another state for X weeks. And that's a lot. That's a lot to ask somebody to do to get the special training. And so we kind of powwowed and we're like, well, how do we bring it here? We are an academic institution. We can teach. And I'm really excited to announce that we are starting the first critical care transport education system in all of California here in Fresno. It's actually starting in March, just around the corner. And American Ambulance is putting it on. We're having outside agencies attend too, so not just their own people. And it's probably going to be a course of about 20-ish people. Right now, you go back east to get trained. So I'm sure if you're somewhere in the middle of our country, Fresno might be closer and cheaper to come to. And the goal is to get more critical care paramedics out there in the system to help all these rural agencies have more expertise to then get these patients farther.
So I'm going to say, like, we're in California, and the fact that there was no critical care paramedic training program in this giant state was shocking when you told me. And it's pretty exciting that now in Fresno, we're starting the first course. We're going to be, teaching critical care paramedics, and we need it so bad. This is really going to help just the population at large around here.
Yeah, and I'm really excited too because I'm hoping it actually helps the paramedics themselves if they want to get another advanced training. Now you have the opportunity. I feel like it's kind of like colleges. If you had to travel across the country to go to college, only certain people would go. Now there's city college, regular college, 4-year programs, state colleges, all right in our backyard. And that makes education more accessible. So I think the more we can bring education to our local area, the more people have opportunity to better themselves and know more knowledge. At the same time, our patients need it. I don't know when I'm going to have a stroke or when you're going to have a stroke or a head bleed. And we need to be able to have somebody. And that really is my mindset most of the times. I live in this town. My family and friends are in this town. What if it's us? And we want our system to be so good that we're so proud when it engages somebody we know and love. Every day they're out there touching somebody, and it's going to be somebody we know and love.
Yeah, I think it's really important because, again, this is our family, our friends, our community. And so you want, when they call 911, for the best people to show up, for them to have the best chance at getting better from whatever it is that happened.
And I think the EMS system and even the hospital system is kind of forgotten sometimes because if you don't need it every day, you don't go there unless you work there, right? You just go about your business. You go to the grocery store, you go to the gas station, you go to wherever your place of work is until something catastrophic happens, right? Somebody has a medical emergency in front of you, somebody chokes. Then all of a sudden you're like, I need those people. We need to activate them. And why weren't they here yesterday? Right? That's your mindset.
Yeah.
And that's totally acceptable. And so I feel like being fortunate to be in these roles, to work in the ER, to be American Ambulance medical director, that's how I take it. Is when you are called, it's crisis for whoever's calling you. Now that paramedic, that EMT, that's their everyday job. They only get called to crisis. But I'm very proud of them because they're well trained and they're coming in ready to help.
And look, let's face it, you and I, we're hospital doctors. So we're used to EMS bringing us just packaged patients with a story. And it is a totally different level of difficulty being out there in the field, having to, figure out what's going on with a scene, making sure it's safe, then finding your patient, caring for them. I mean,
it might be raining on you, snowing, ice on the side of a highway, in the middle of a forest fire, you name it, they're there. Yeah, and it's really, really cool that they get all this training and we get to benefit, we as humans, right, living in this world, get to benefit from the EMS systems that we live in. And to be honest, people listening, every state is different, and every county is different, and every city is different.
And every country is different.
And every country is different. So I highly recommend, if you haven't had to engage your EMS system, do some Googling and see what is my EMS system, what are the regulations. If I called 911 right now, who would respond? It's probably very different if you live in rural Idaho or rural Iowa versus if you live in an inner city, New York City, right? Things are just different.
Yeah. So. Or for example, if you're in Europe, the doctor might show up on the ambulance.
That's right. Because they do it to every system does a little differently.
Yeah. So now we just mentioned that we're not out in the field and it's so difficult. And I wanted to talk about one day when we were out. It was just a fun night out. We're all off, along with some of our other friends. We're trying to have a good time. And I remember we were somewhere where you and I, we weren't sitting together. You were sitting a little bit ahead of me. I was a little bit behind. But all of a sudden, I noticed you stood up and turned back and looked at someone, and you just started walking towards them. And you gave me this weird look you better get up too. So tell us, what did you notice?
As the person sitting next to me basically was trying to die. And so there's certain noises people make or certain, I don't know, we work in emergency medicine. This happens a lot. So I looked back at him and I was like, oh, this is not going well. So I remember, and to be honest, it's kind of a blur because it happens so fast. And it's in your mind, you just go into work mode, even though we were in social mode. And I remember looking at somebody, telling them call 911. I remember looking up because I knew I had colleagues. I was like, where are my friends? Where are my people? And then we had to get this gentleman out of his chair, onto the ground. He still had a pulse at that time. And then it was great, out of nowhere. You appeared. 2 of our other friends were also ER docs. One's an ER nurse. They just appeared. And then this gentleman did lose his pulse and we started CPR right then. It's he never went a second without either his own heart beating or us jumping in. So we were now in the field So I was like yelling at the person sitting next to us, call 911, find us an AED, like all these things are happening at once. And we, as you remember, you jumped right in and we started doing CPR.
Yeah, I remember you had your hand on his pulse and you were like, I have a pulse. And then you said, I don't have a pulse. And the minute you said that, I think it was our friend Ronnie, who will have to come on the podcast one day, but she started chest compressions.
That's right.
And then we kind of took turns. So there were 4 of us, you, me, Ronnie, and our other friend Amy, who we just kind of went around doing chest compressions, checking for pulses.
Yeah, getting the AED, like doing all the things you do in a code. But I realized there, and I don't know, we haven't really talked about this part of it, is harder in this pre-hospital in the world because like someone had to go find the AED and like you had to get his shirt off and he was really sweaty. Like in the hospital, the AED sits right there and their clothes get cut off and you have towels. In the hospital, we're prepared. Out there, it's like Patil was wearing a dress. Like we're not prepared to do CPR.
Yeah, we were kneeling down in dresses and heels. Again, we needed the AED, so that's an automatic external defibrillator. So you can shock someone with that if they're in a heart rhythm that you can shock them out of. And we knew somebody was looking for it, but we didn't have one yet. We knew that paramedics had been called, but they weren't there yet. And so it was really kind of just us in the beginning. By the way, this was a really crowded place, right? So there's
only a few hundred people watching us.
Only a few hundred people. And I remember at some point, someone was like, only medical professionals should be allowed, near him. And
well, I think they said like, we need a doctor or something.
Oh, yeah.
Because we didn't identify ourselves. And honestly, we probably should have, but we just went into mode, right? Like, this is what we're doing, work mode. And then I think a bystander was like, we need a doctor.
And I think at that point, no, I do remember that now, because at that point, I'm pretty sure I yelled, maybe the loudest I've ever yelled, we're all ER doctors here.
Yeah, you did.
And that shut everybody up so that we could work.
My son was actually there, and he's, I guess, 12. And he remembers that. He said, Mom, Patil yelled, we are doctors. And I said, yes, you just let everybody know. I think maybe because we were females, maybe because we were out, because you weren't a dress. I don't think we looked like doctors. But we were. And we did a really good job of good CPR. And, fire came, and then EMS came. And it's funny because I recognized the paramedics because I'm their medical director. And Patil, you're on the podcast with them, so she knew us. And Hillary is her name. She did an amazing job.
Amazing. And we immediately then let Hillary take over because we were like, this is your scene. We're your worker bees. Tell us what you want. And she was like, just keep doing the compressions while I work on an IV and get him on the monitor and all of that.
Yeah, she had to give meds to him. And, he ended up a wonderful success story. He got taken to a local hospital nearest where we were, and he walked out and he's back at work and he's doing wonderful things. And so it's like a great success story why bystander CPR matters. So I'm just gonna make a really quick plug here for those of you listening. If you have a chance, you can go online and just watch hands only CPR, or you can attend a class. But everyone in America, I think, should learn how to do hands only CPR. You might be saving your friend or your loved one, and that really makes that that continuous CPR, never stopping. You rotate people out every 2 minutes, but that really saves lives.
And so just to clarify, what we mean when we say CPR and hands-on CPR is the chest compressions. So I know like back in the day, people would talk about, oh, you do some compressions, then you give rescue breaths, then you do more compressions. And that's actually not the best model anymore. Now we know it's all about compressions.
If you think about it, when anyone has a medical emergency and their heart stops, they probably have a full breath of air in there, right? Unless you're underwater and drowning, you have a full breath of air. So you have about 3 minutes before you need more air. But what you need that second is a heart to pump that oxygen around, to pump that blood around. And so really high performance CPR, we call it, is just compressions only. You're going to, no interruptions. You're going to do it at a rate of 100 to 120. And you're going to let that chest bounce up. And hopefully while you're doing that, like you're a bystander, you're at the grocery store, someone collapses, you're going to yell to somebody, call 911. Because depending where you are, the professionals arriving might take 5 minutes, 6 minutes, 7 minutes. If you just stand there and stare at them in 6 minutes, there's not much oxygen or blood support or anything for that poor person's brain. And then what happens is maybe you get them back, but their neurological survival is really gone. So the pre-hospital, like that human next to them matters. That bystander matters more than anybody.
It totally matters. Now, also, if you're doing really good CPR, so you're pushing down, you have good chest recoil, the blood might be pumping so good that they look like they're trying to like grab at you. They might seem like they're alive, but the minute you stop the chest compressions, you will feel that they do not have a pulse.
Exactly. That freaks everybody out. So if you can imagine, like in this case.
And it happened in this case.
Yeah. And we see it in the ER a lot. Like if a person comes in alive and their heart stops and we do CPR right away, you're pumping the blood so good, their brain is getting good blood. And they like open their eyeballs and like look at you. But as soon as you stop the CPR, then the blood supply stops, right? And so I think people freak out and go, are they alive? Are they not? And so that's why we keep a finger on the pulse, because you're doing good CPR, you should feel that pulse everywhere. You're basically artificially keeping them alive.
So in this case, that happened. And then also what happened was we were just every 2 minutes rotating out doing compressions and like a well-oiled machine. And when the fire department got there, I remember like they kind of, I think, saw that we were doing such a good job that they let us keep doing the compressions. And we told them who we were at that point. But then I think afterwards, when we were thinking about what happened and how that could have, run smoother, and it actually ran pretty smooth, I have to say. But that's the way we are. We're always like, how can you do better next time? What did we learn from this? What I learned was, hey, that was a crazy experience, and I have so much respect for medics. And you took away something slightly different. Yeah, what did you take away?
Yeah, I took away that I don't think the first responders were going to do CPR or want to do CPR the same way I wanted to do CPR. And so from that, this patient had a wonderful outcome, did great. So it wasn't about the individual. My brain, I went to the system. And I'm like, how are we going to get everybody to do CPR?
Yeah, I think it's funny because I thought more of the person. I was like, this person is back to normal, back at work, doing awesome. And you were like, that's great. But if we weren't there doing that level of CPR, what could have happened? What is happening? Could we make this better?
Right. And I think that sentiment is like what resonates in my brain. And to be honest, right away, I didn't have a good answer for it. I was like, how are we going to do this? Our system's big, right? So I think American last year around like 150,000 calls, right? You think about first responder agencies, every fire department in our town, every cop in our town. Like, how do you get more bystander CPR? Like, what if I had sitting by him, right? What if somebody else was sitting by him? Like, what if they done CPR? So that's where my brain just resonates. He's going in circles, like the what ifs. How do we make sure everybody has that same chance to walk out and continue their lives?
And I think something that we didn't realize was that we're really up to date on the latest and greatest in CPR, which is this high performance CPR. And then I think you realize, wait a minute, the first responders haven't learned high performance CPR, but it matters to them more even than sometimes it does to us in the hospital.
Right. And so that was great. So just to share, as you know, Fatil, like we went on this big multi-system training mission. And so in March, there's a partnership between American Ambulance and Fresno Fire, and they're an amazing group to work with. And so I enlisted Miranda Lewis, Dr. Lewis, as our EMS medical directors for the county. And she did special research and training in high-performance CPR in Seattle during her EMS fellowship. And this was like a really big project for her. And so she helped us bring it here to Fresno. And we trained over 1,000 people in high-performance CPR. So when I say we, it's not like me doing all this, right? So I'm the idea woman, right? Miranda's the idea was like, we train the trainers, right? So you do a course to teach some of our training officers how to do it, and then you do a course for them, right? And then they go. But every Fresno City Fire Department employee and every American Ambulance employee went through this training. So over 1,000 people trained, and then now every new hire academy, right? Every new group of paramedics, every new group of EMTs, every new group of firemen. And then they did a high performance CPR course here. It was 2 days. It was free for all the outline agencies. So, Clovis Fire, Sanger Fire, everybody. So the idea is now we've got the two biggest agencies in town already doing it, and then to expand it. And I love to share with you if you guys don't get too nerded out by numbers.
Oh, we're all nerds around here. Please give us numbers.
So I love it. So, there's actually a person, his name is Ben Wheely. He's amazing in American Ambulance, who tracks all this and looks at all this. So the government actually requires you to report cardiac arrest survival rates. And so this is a governmental thing. It's a database that all hospitals put into. So if I collapse here right now, CPR gets done, they take me to the hospital, like whether I survive and walk out or whether I survive and go to a nursing home or I don't survive is all reported. So that's how we get these numbers. So prior to this initiative, if you had a cardiac arrest in the prehospital setting and you had bystander CPR and you were in a shockable rhythm, right? Those are the most salvageable people, right? You had a rate of 9% of just being able to walk out.
So only 9 out of every 100 people can just get up and walk out of the hospital normal after an event like that.
Go back to their jobs, back to their families.
So that's it. Just 9 out of 100.
That's it. But after our intervention, so after we've trained everybody, we've led this huge charge, over 1,000 people got trained, the rate went to 21%. That means discharged alive, back to work, no deficits.
Okay, so that is a huge difference. So I just want to say, like, in medicine, we don't do a lot of things that have these huge numbers. And don't be fooled by what you see on TV. Like on TV, I feel like you just do CPR and then they come back to life. That's not the case. So at first it was 9 out of every 100 were walking out normal. Now after doing this high performance CPR, 21 out of 100, that's a big difference.
Right. And our goal is 60%. That's our goal, is that 60 out of 100 walk out. So every town reports their survivability rates. Now, every town is different. So one of the best places to die in America is in a Las Vegas casino. So if you hit the deck, all their security guards are trained how to do CPR, right? The bystander CPR rate is super high. Remember we talked about it really matters who's on scene next to you, who's sitting next to you. So our ability to sit next to this person and do CPR really saves their life right before the fire showed up and before EMS.
So what are the rates in Vegas casinos?
90%.
Really?
Because they're down to someone starting compressions is like less than a minute. Like they're there. Security guards everywhere, right? They're worried you're going to cheat on gambling. They're worried. So if you go to the Las Vegas casino.
But all those security guards are trained in high performance CPR.
And then the next one of the other great places is Seattle. Of course, high performance CPR was created out of Seattle. I think they're really considered what I would call a highly educated town. So everyone in that town gets CPR in high school. Everyone in that town knows bystander CPR. And so we are starting that now as our next big adventure is we're partnering with, I think it's Central Unified and Sunnyside High and trying to get the high school kids, right?
Yeah.
You get the young generation keep coming up and we're doing this huge community push. But going back to that, it's like the whole piece of hyper CPR is bystander CPR. And then when they're on scene, like what we talked about, those compressions. At this time, we do ventilate for you, right? So we are going to give you oxygen by then. But you limit the hands off the chest time. So you can imagine, I take my hands off the chest, all the blood flow you circulating going up to the brain now stops. And the goal is not to just get your body back, but to get a brain back so that human can function.
Yeah, we want somebody to just go back to however they were functioning before this event happened.
Yeah. And I think it hurts my heart that where you code determines your survival rate. To me, it shouldn't be that. It should be wherever I am, whether I'm traveling, to Kentucky, or I'm in Seattle, or I'm in Fresno. We should all have equal chances. Now, granted, if I'm in a rural place by myself, yes, I probably know it's going to find me. If you're in a city in America, I think your survival rate should be pretty much the same, but they're not. So that's like our drive here in Fresno, that it's like we're going to make sure our survival rates are the best they can be.
That's huge. And I feel like our rates are only going to go higher and higher and higher with all these interventions.
Yeah, we're really excited to report just that small intervention is already doubled. So I imagine it's going to double
again. And that's
again.
over such a short period of time.
Right. So it's very exciting. Pre-March and post-March, and now we're recording this in, what month are we? January.
Yeah, January 30th. I really love this story, and I wanted you to come on to tell us about, not just high performance CPR, but about how this idea even came about in the beginning, because I feel like so many of us think, oh, well, I'm just one person. What could I do? How can one person make a difference? But here it is for today. You're our one person that is like, look, you have these ideas and you make them happen. And this is really impacting so many more lives.
Yeah, that's why it's so exciting. And so I think my take on that and telling people listening is, even though you're just one person, you can make a difference. Now I recruited a lot of help, right? So like for the podcast, I recruited your help, right? I can do it all down. And then it's like for the time for CPR, I recruited an expert, Miranda Lewis, to be like, help me lead this. But sometimes you just need to get the right people in the right room to make change and not let it drop. So our event happened many months before we got this rolled out. Like we had to get the right people in the room, the right buy-in, get the right plan. Because if I myself was trying to train 1,000 people, that would take me over a year, right, to meet with those people. This training is like a 4-hour training, right? They go through. But I think getting Fresno Fire to say, yes, I want to know the best CPR around, getting American Ambulance, getting everybody involved is great. And so I think when you're one person, don't give up if one door shuts on you and they say, oh no, this is just the way it is. I think you have to say, well, why? And can we make change? And so I think, and that's, I don't know if it's a gift or a curse, because if I ask my family, they're like, oh, here she goes again. One more project. But to me, it's like, I don't know, that's where my brain goes to. It's like, how do we make it better for everyone?
Yeah. And don't give up. I think you and I are both cursed with that eternal optimism thing.
Right.
And it's like, what do you mean? No, fine. I'll go ask somebody else.
Right. Like you can't tell me no. And that's kind of a funny story. I don't know if you've heard this before, but when I was a freshman in college, I got the first C of my whole entire life in calculus. Okay. I'm a straight A student. I wanted to go to medical school since I've been 7 years old. And then my counselor said, Danielle, you got to see, you can't go to med school. And guess what I did? I said, I need a new counselor, because it was like, no. You don't understand. So of course, then I got a math tutor. I took calculus again. It's fine. I got all A's since then. I got into med school, obviously, and did very well. But it's like, you can't give up. Now, 10 other people might have said, oh, my counselor said I can't go to med school. I got a C. I'm going, C my first year as a freshman, my first semester. I mean, you could just give up and give up your dream. But the internal officer was like, oh, no. I can't let one bad grade, because during that class, I could be like, I want to pull this out. I want to be fine. I'm going to ace that final. But I use that as an example to show people, if someone tells you something. Now, if someone had said, oh, I want to be an Olympic swimmer, right, I probably cannot become that right now. So there are limitations for optimism.
Obviously.
But I feel like when you're young, if somebody tells you no, don't just give up. Go ask somebody else, and it can work.
I did not know you got a C.
I know. Ooh, don't tell my kids.
Oh my God. Yeah. It was like one lone grade. I can't believe that counselor would even say, oh, now it's over. You can't go to med school. That's ridiculous. I'm so happy you got a new counselor.
Right. I mean, I didn't tell that counselor that. I'm a nice person. I said, oh, thank you so much. But that's the next step I did. Was I told myself, you got to find a new pre-med counselor, because you need someone to say, how do I overcome this? Yeah. How do I take this class again? How do I show the medical admissions committee that, I had a bump in the road and this is what I did to address it? And I think people don't realize when you start college, you think you can do it all. Really, you're taking, so many units and doing all these labs and all these things. I was playing college sports at that time. I was doing so many things that it's like, oh, okay, I need someone to get me through this. And then I think it worked out great. You can write about it in your essays to medical school and be like, look, I have this blip and this is how I fixed it.
Yeah.
But yeah, for someone to tell an 18-year-old you're done with your one bad grade, it's like, oh, yeah, got to get other resources.
Oh, man. Well, Danielle, because this is human school, we still have to, and that was a good lesson, but I need to know, since this is human school, what is a lesson you have either learned lately or you feel like you're learning right now?
Ooh, that's a hard question. I feel like we're always learning, but for me, you guys will laugh at me, I'm pretty tech challenged. The latest thing I'm working on is my electronic calendar, how to sync it with all my kids' calendars, the husband's calendar, my personal calendar, work calendar, and still save some downtime. I get teased a lot, especially by my brother-in-law, that if I have 5 minutes of extra time in my day, I'm going to shove it full with 20 minutes of other things. And so I'm really kind of taking that to heart and really trying to say, here I am in my career, in my family life, what's important, because as we all know, sometimes what's on your to-do list, what's really important doesn't get done. It's what's nagging you. Oh, I got to pay DMV to renew my whatever. I got to do this, but that's not really what's really important. To me, really important was doing high performance CPR, or maybe writing a research paper, something that drives me, or something that makes me get up in the morning.
Yeah.
It isn't that like, oh, did I get, the PG&E bill paid right? So really just calendaring like how to put non-urgent things that need to be done, and then putting the things that still drive us and make us get out of bed in the morning a priority.
Well, it's so true. I mean, I always say schedule is life. So if you don't know what's on your schedule, you don't know when your off time is going to be. And we all need like a little bit of off time. So I'm glad that you're working on that. I think that's awesome.
Yeah, I hope I can report back in 2025 is the year of the calendar. I'm going to get better at it.
Well, I love that for you. Thank you so much for coming on the podcast. And I loved hearing your stories, and you're welcome to come back anytime.
Perfect. Thank you so much.
Bye, everyone.
Bye-bye.
Please like, subscribe, share, and download the podcast. And again, you can find us at Human School Podcast on Instagram. I'd like to thank Dr. Zac Efron for the theme music. And I'd just like to make a general disclaimer that any of the institutions I work for, including Community Regional Medical Center, UCSF, UCSF Fresno, and American Ambulance, have nothing to do with any of my thoughts or opinions, and so we'll kindly leave them out of this. Thanks, everyone. See you next time.